And good morning, everyone, and welcome to the Penn State College of Medicine COVID-19 Echo Series. We're delighted to have you join us for another session. My name is Jackie Sable. I'm a member of the Echo team, and I'll be facilitating today's session. A few quick announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box for our record-keeping purposes. Please stay muted unless you are speaking. You can use *6 on your phone to mute and unmute, or the microphone icon on the bottom left-hand corner of your Zoom screen. You can also use the chat for communicating. We realize that question and answer time is important to you, and we try to categorize and address as many questions as possible here. But if there are any unanswered questions, we always follow up via email afterwards. If you have suggestions for future COVID-19 ECHO topics, please share via the chat tool, or you can email us at echo@psu.edu. Please remember that no personally identifiable information is allowed when we're discussing cases. We are recording these sessions, and we share all materials and the recordings after each session. In the spirit of all teach, all learn, we'll be on a first name basis during the session. For those who are not familiar with Project Echo, our Echo sessions will always begin with a brief lecture and are followed by either a case discussion or questions and answers. Today's session will include a brief lecture and case discussion on healthcare response to intimate partner violence, considerations for the coronavirus pandemic by Dr. Jennifer McCall-Hosenfeld. And there will be time for question and answer in the middle of that. But during the lecture, please feel free to put your questions into the chat. We have a team of specialists from Penn State who join as they're available, and they help to field questions. But remember that this is all teach, all learn, so everyone can share both questions and answers. And with that, I'm going to turn things over to Jennifer. I believe we have another panelist that she will introduce. Thank you.
Thank you. I'm trying to advance the slides. Okay, thank you very much. This is one of Jackie's slides telling about the funding for the COVID-19 ECHO project. And here are the disclosures around COVID and around ECHO. And this is the panel of experts. Okay, so thank you, Jackie, for that kind introduction. Good morning, everybody. I'm really happy to be here in an all teach, all learn environment to talk to you about the healthcare response to intimate partner violence during the COVID-19 pandemic. So let's go ahead and get started. Okay, so I do not have any relevant conflicts of interest to disclose. Just to go over what I'd like to accomplish today, I want to talk a little bit about the risk and epidemiology for intimate partner violence and discuss why the coronavirus pandemic and how the coronavirus pandemic may have exacerbated or changed some of that risk. One of the things that has happened in my group, will introduce myself. I'm a primary care physician with a longstanding interest in domestic and sexual violence. And one of the disorienting experiences that myself and other providers have had during this time is a transition to telehealth, and thinking a bit about how do we assess for intimate partner violence or IPV, given the fact that we are transitioning onto new platforms. So we're going to review some of the best practices. And then I've brought one of our trusted colleagues, Elyse Szurgot from the Harrisburg YWCA, and she's going to tell about her own experiences providing care during the coronavirus pandemic. And this differs across so many situations. Okay, so just to get started, I did want to remind people how we define intimate partner violence, because there are many definitions for intimate partner violence in the literature. In this talk, I'm referring to physical, sexual violence, stalking, and psychological aggression. This can be perpetrated by current, former spouses boyfriends, girlfriends, persons of any gender, dating partners, or ongoing sexual partners. And these definitions are consistent with the CDC's most recent definitions. To give a little bit more granularity, physical violence involves the intentional use of physical force with the potential for causing death, disability, or harm. And this is oftentimes what people think of when they think of domestic violence, but there are other types of IPV that are always very important to evaluate for, and they include sexual violence, which can include a sexual act that someone has committed against another person when they are either do not give consent or are unable to give consent. Stalking, and the definition of stalking includes a pattern of repeated unwanted attention that both causes fear or concern for safety, and it could be the safety of yourself or another person. And then importantly, it's not to forget psychological aggression, because psychological aggression is also known to have significant adverse health consequences. And these include things like expressive aggression, name-calling, humiliation, degrading, appearing to be dangerous, even without actual physical violence occurring, and coercive control, such as limiting access to transportation, isolation, threatening to harm self or others, so in a way that is coercing the person into doing behaviors that they wouldn't otherwise do. Again, these are consistent definitions from the CDC and the National Intimate Partner and Sexual Violence Survey. So it's really important that we think about intimate partner violence, and we've known this in the medical community and certainly in the medical advocacy community for a very long period of time. But at least 1 in 4 women and 1 in 9 men report a lifetime history of severe forms of intimate partner violence, and this includes contact sexual violence, physical violence, and or stalking that is perpetrated by an intimate partner. And importantly, these reports of 1 in 4 women and 1 in 9 men experiencing these forms of intimate partner violence also felt that they had a significant negative impact on their life, such as an injury, significant fear, need for access to additional services. So this is really important. Very, very common, and it affects health. So during the coronavirus pandemic, many of us are forced to stay in our homes. And I have seen these images on social media. I found this one on Reddit. And it's a really positive message. It says, you're not stuck at home, you're safe at home. And this message is trying to encourage people to enforce social and physical distancing guidelines, which we all know is critical to controlling this virus, preventing its spread, preventing its propagation, and reducing the possibility that healthcare systems become so overwhelmed that we do not have adequate healthcare providers or ventilators to treat patients who become critically ill with coronavirus. So this message is an important one, but I think as we reflect on what's happening with victims or survivors of intimate partner violence, you're safe at home, the message you're safe at home may not be true. So you can see how the coronavirus has potentially set us up for a situation in which intimate partner violence can potentially be worsened, despite these attempts at positive messaging around, and the very important attempts at positive messaging around staying home and staying what one would hope would be safe. So what do we know about intimate partner violence risk in a disaster situation? Well, we know that the risk for intimate partner violence has been increased by prior disasters. So we know that intimate partner violence perpetration has occurred in the context of increased stressful life events. And I think we could all say that living through a pandemic, the likes of which almost no one's ever seen before, is a stressful life event. There have been reports in our medical journals about increases to domestic violence service centers more than a year after Hurricane Floyd, increased risk of domestic violence victimization after Hurricane Katrina in areas that were affected by that. And even going back as far as the 1980s, there was a journal that published a report of a 46% increase in domestic violence that occurred after the eruption of Mount St. Helens. So we know that disasters can increase the risk of intimate partner violence victimization for probably a lot of reasons related to stress. Unfortunately, there's a lot of concern that this particular disaster, the COVID-19 pandemic, may uniquely worsen the risk of intimate partner violence. We know that there's many risk factors for family violence that are likely to be increased by the COVID-19 pandemic. These include factors such as increased rates of unemployment, as so many people are losing their jobs as businesses are shut down due to social distancing recommendations. Reduced income is another stressor, limiting access to external resources, increasing problems with social support, so limiting access to social support for potential survivors. And alcohol abuse is a risk factor for intimate partner violence perpetration, and this is more likely to happen in the home when bars are closed. The other issue that has been raised is that many times when there's a disaster like Hurricane Katrina, people were coming together and being in situations where communities saw each other and had the support of each other. Now we're seeing more isolation and staying apart, which could be a recipe for increased intimate partner violence. Okay. So again, we have these shelter-in-place orders, and it's important to remember that there's widespread organizational closures. And we don't know at this point how long these are going to continue, but it appears that they're likely to continue for an extended period of time. When you increase social isolation, there's also a reduced opportunity for victims to disclose intimate partner violence potentially. There are places of reprieve for victims, such as churches, libraries, and schools that they may have had access to that they no longer have access to. And it's also important to remember that as we increasingly are relying on media such as this to connect us to other people, victims of intimate partner violence are subject to technological abuse when they potentially live or are monitored by a perpetrator who restricts their use of electronic media, surveillance of social media, surveillance of the internet, use of their cell phones. So this could potentially be exacerbated by intimate partner violence as we try to stay connected to each other through social media and through other forms of technology. So what have we seen so far? There have been troubling numbers, and again, primarily these are from the media. This is too new to have some well-designed observational studies in the academic literature, but in the media we've seen tripling of domestic violence reports during the shelter-in-place orders in China, in France, again about a 30% greater, Brazil 40 to 50% greater. In Spain and the UK, they've seen reports of increases in domestic violence-related homicide. They've seen a few other reports like this in the United States, and some very disturbing reports of perpetrators using COVID-19 as a weapon against their victims, including things like forbidding hand washing and threatening to forbid medical treatment for victims who may become ill with COVID-19. Very recently, there was an article in the New York Times about a drop in domestic violence report that authorities found very concerning because they were interpreting this as potentially evidence of increased technological abuse and isolation rather than actually decreasing domestic violence as the pandemic has made New York City a situation where there's extreme social isolation. So, as I mentioned, myself and I'm sure many of you on the call have had to rapidly transition primarily to a telehealth platform. And in doing so, we still need to screen for domestic violence and evaluate for domestic violence, which has been a bit disorienting as it's a new way of going about our business. So why do we do this? So we've known for a long time that identification of domestic violence is important and it's very relevant to healthcare. Back in 2013, the United States Preventive Services Task Force told us that they had moderate certainty that screening women of childbearing age for intimate partner violence has moderate net benefit, meaning this is a routine preventive healthcare service that all healthcare providers should do. And I will just, as a sideline, note that there are other guidelines that refer to screening all women and men. I point to the one, the United States Preventive Services Task Force, which specifically refers to screening women of reproductive age, just because the evidence is strongest in that particular group, because the most studies have been done in that group. And the reason that we've been doing this since 2013 as part of routine preventive healthcare is because, as I noted before, intimate partner violence has a high prevalence and a high lifetime comorbidity. It's a health problem among other problems. And that we do know that if we screen people, we can actually identify it. And there are effective interventions, particularly as we partner with individuals like the Harrisburg, like Elyse, and individuals and organizations like the Harrisburg YWCA, who can really help us in healthcare provide services. And we know that there's very little risk associated with screening. But I think one of the questions that we've thought about in healthcare is a lot of this evidence was compiled in the setting of in-person screening. So what do we do now? Sorry, a little bit of a delay. So I want to open it up to a case. So this is a hybrid case. And I'd like to open it up to discussion here, sort of in the middle of the program. So Miss M is our 30-year-old woman, and we've been following her in our primary care practice. She's a generally healthy young woman, but she does have a history of uncontrolled asthma. And for the first time, you want to follow up on her asthma, and you're contacting her via a secure online video platform to assess her asthma during the COVID-19 pandemic. You're worried about her. This is a respiratory disease, and you want to make sure that she's doing okay. You're especially concerned because you've uncovered a history of medical abuse and have noted that in the past, her partner has limited access to her asthma controller meds on occasion. And so this gives you pause. So I guess my question is, and we don't have to, if you don't feel like answering, that's fine, but I'm wondering what the group feels like we should do as we think about initiating this online video visit. Open it up at this point.
So feel free to enter any comments or questions into the chat, or go ahead and unmute your microphone.
Encourage her to use headphones, from what Kimberly said. Great idea. Find a quiet, private place. Encourage her to use nonverbal interactions if needed. Excellent. I'm reading the chats as they come up, so these are good ideas. I'm curious if among the group people thought about this. Recommend the use of the chat. Use the chat. Use the chat itself if you can. Yeah, on this particular, if you can on your platform. So lots of creativity. Ask for her preferences. Thank you. That's really, really important. What does she want to do? Give her some control. So I think you've come up with some really great ideas. In the interest of time, I'm going to move forward and we can talk about these more. There are some guidelines for telehealth that I think in my review I came across, and also in my conversations with other people who do this work. I will say I'm not a telehealth expert, but the good news is that many of the telehealth best practices that if you have been transitioned onto a telehealth platform that we've been asked to do anyway are the best practices that should be used for screening for intimate partner violence. So obviously, not just screening, but also doing a diagnostic interview, because screening is really for an asymptomatic individual, and doing a diagnostic interview is for someone who you may be you may have another concern about. So obviously using a secure and HIPAA compliant platform to contact the patient is really important. Making sure that you know where you are, and that as the provider you're in a secure location, and verifying the location of the patient, that the patient is in a secure location as well. So I love the idea of making sure that there's headphones so that you're increasing the privacy. And I'm sorry, I can't remember who it was, but someone said, asking us for her preferences, confirming with her that it's okay to proceed. Identifying a backup means of communication in case you are disconnected with the patient. You don't want to get into the middle of a complex conversation and only to discover that you can't get back in touch with somebody. One thing that is really important, and I think is particularly tricky as we move forward, is we don't know who else is in the room. So I've been thinking a lot about that. And certainly as part of the best telehealth practices that I read, one of the comments from an author was, make sure there's nobody, and the word was lurking in the background outside of the view of the camera. I think that's a very tricky thing to do, but I've been thinking about how I would go about doing this. And what I was thinking is, one of the things I always do is ask who else is important and who else is around. And I think it's okay as a healthcare provider to say, hey, I'm using this new platform. I want to know, can anyone else hear you right now? Is there anyone else that I'm addressing? Are we talking? Is there anyone else in the room? Before you even go into more private or concerning situations, and sort of verifying that that this is a private conversation. And then if there are other people in the room, then I think as a healthcare provider, you need to proceed with that information and perhaps use caution depending on the kinds of questions you might want to ask. The other consideration, of course, is if you have an electronic medical record or EMR, you need to clarify who has access to EMR, billing records, and those types of things. Electronic medical records are something that can be monitored by an abuser. So how you document may need to be something that you consider within the EMR. Can the EMR be partitioned appropriately such that only the patient has access to it? Are there places in the EMR where you're certain, for example, an electronic communication is not going to be monitored? And so you can get some of that information as part of your routine up front. We're doing a telehealth visit. this is what I need to know as I move forward, just as part of good practice. I think that's important. And then if there is a support person or an additional person that someone has identified that they would like you to share information with, sort of getting a confirmation of that is important as well. Sorry, I put this slide in here just because these were some of the best telehealth references that I could find regarding telemedicine and telemental health care and safety planning in that setting. So it's just there for you to see. So I wanted to remind everybody about the Futures Without Violence mnemonic that we use when we're approaching screening and assessment for intimate partner violence in healthcare settings. And the word that is used are cues: confidentiality, universal education, and support. And this is available at ipvhealth.org. So Futures Without Violence is an organization that has been providing guidance and best practices to healthcare providers who care for survivors of intimate partner violence for a very long time. And this is the program that they recommend. So I wanted to share it with you, but also sort of think together a little bit how we may have to modify in the telehealth environment, how we perform the cues interactions. So as I mentioned before, and as everyone mentioned in the chat, the first part of cues is confidentiality. And again, when I'm in a clinic, I just say to the patient, if they've brought in a partner, I say, this is the part of the visit where I always discuss with the patient alone. It's just our clinic policy. I don't make it specific to any one patient or any one encounter. I say it's just our clinic policy. We always have to see the patient alone. Your patient is free to disclose anything that we discussed with you later on. And I'm able to know who's in the room. In this situation, how do you ensure that your patient is alone? So I think going back to sort of saying, it's really important that I know who's around you. This is part of my best practice. It's just our policy. We need to know who else is in the room. Can you just tell us, because these are the questions that we ask of everybody. So it's not perfect, but I think taking some time and just making sure that you have done as much due diligence as you can to make sure that you're in confidentiality, that you're alone and you've disclosed the limits of confidentiality. Additionally, it's important to know what your limits of confidentiality are. So it's important that she knows that sensitive topics are going to be discussed, and then also to say, hey, everything that we're talking about here is confidential, meaning I won't talk to anyone else about what's happening unless you tell me that someone's hurt you, you require or that someone else has been harmed, because this may require a report to the police. In those cases where you are a mandated reporter, and I will just say that mandated reporting is outside the scope of this talk, because it actually is a very complicated issue for adults, but when you are a mandated reporter, it's important to partner with the person that you're reporting to and make the report together so they know what's being said. Okay, so then after you've sort of established confidentiality and the limits of confidentiality, it's important to use some sort of a framing statement, right? Because it's really, when you're assessing for intimate partner violence, it's important for the patient that you're working with to know that this is something that you do with every patient. These are just some of the framing statements that people use. Violence is very common. It affects women's lives. I see a lot of patients who have this issue, and there are resources available to help. So I ask everybody these questions. I showed an example of the HARC questions. This is one of the screening tools. I like it because as a busy primary care provider, you can ask 4 yes or no questions and get at essentially all the domains of intimate partner violence, including physical, mental, sexual and stalking with the fear issue. That's one of them. If you look at the United States Preventive Services Task Force statement, there's quite a few that actually have fairly good psychometric properties, meaning their sensitivity and their specificity are quite good for screening. And then if someone has screened positive, you can proceed with further questioning and a diagnostic interview, as long as it is safe to do so and the patient is okay with that. So the other thing that it's important to remember, and even as we're transitioning on to these new platforms, we have to perform universal education. So what's recommended from Futures Without Violence is that we use written materials to talk with all patients about healthy and unhealthy relationships and the health effects of violence. Obviously, if you're in a telehealth setting, written materials may not be appropriate. So it just may not be practical. You may not be able to pop a pamphlet in the mail. You might be, but it may not be safe to do so. So certainly trying to figure out what kind of takeaway it's safe for the patient to have at this point. Just the knowledge that this is common and that you are available for help should you be needed in the future. And then, phone numbers, contact informations, or even just the idea, great, I'm glad nothing like that is happening to you. You can always circle back to me anytime. Just call my office and we can talk about it more if anything like that were to be happening to you or to someone you love. And then we can put them in touch with our colleagues like Elyse. And just finally, the last part of CUES, which is something we should still be doing, is support health promotion and documentation when it is safe to do so. Remember that our goal when we ask questions about domestic violence is not disclosure. Our goal is providing an opportunity for patients to disclose if they so desire and feel that it is safe to do that. If they do disclose, make sure that you talk about what their wishes are and encourage harm reduction and make what we call a warm referral to our domestic violence partners. Here at Hershey, it's the Harrisburg YWCA. And if it is safe to do so, if you feel that this will not be monitored, you can document the disclosure and certainly make follow-up. It's really important to follow up because even if you make a referral to your DV partner, the patient may not be able to complete the referral. It may be safer for them to come back into contact with the healthcare provider. Just a reminder of what do you say if you get a disclosure. I think some people, it happens for some people frequently and for some infrequently. It's important just to quickly understand the impact of the abuse on the patient's health, the pattern and the history of the abuse. For example, I think one of the things there's a lot of concern about right now is abuse escalation as people are spending more and more times isolated at home. And abuse escalation, threats of violence, introductions of firearms are all risk factors for homicide, which is something that we are very concerned about. And certainly our domestic violence partners can help with that. Validation, understanding that make sure that you take time to just say to the patient, you don't deserve to be treated like that, because this is often not what they've been hearing for a very long period of time. I'm sure many of you are familiar with the construct of gaslighting, but essentially victims and survivors of chronic domestic violence often hear and internalize messages that they are getting treated badly because they deserve to be treated badly. And as healthcare providers, you're in a position sometimes of authority where if you can actually re-highlight this and say, you did not deserve that. You don't deserve to be treated like this. Nobody deserves to be treated like this. That can actually be help the patient to reclaim some power. We talked about providing referrals, and we'll get more information from Elyse on that. And then if you can, some information about safety planning. This again is something we can also partner with our DV partners. And then if you are required to perform some kind of report, make sure that you do so with the patient's knowledge. Ideally, when you're in the same room with a patient, that would be ideal. But in this circumstance, it's important to at least know, for them to know that you're doing this because you have to, but they're going to know and they're going to be empowered to have knowledge about everything that is said. So those are just some of the sort of guidelines on how we would address a disclosure. Okay. So I just wanted to share this with you because this one was new to me. I actually saw this yesterday. So the Women's Funding Network has actually created a visual hand signal for the COVID-19 pandemic. And I hadn't frankly seen this before. As I mentioned before, I work with the organization Futures Without Violence, and I trust them very much, and they were propagating this hand signal as well. So the idea is, and I think somebody actually had mentioned in the chat, which I appreciate, using nonverbal communication, that there is this signal for help requires you to basically put your thumb in. I am not signaling for help, just to be clear. I'm demonstrating the signal. And close it. And if you are to hear that, see that signal, basically asking, maybe reaching out at another time, asking only yes or no questions, and kind of letting the survivor speak to you about what they need. So this is something that was new to me. I actually hadn't seen it before, but I think in the era of domestic violence, it's something, and increased use of telecommunications, not just for healthcare providers, but for lay people and for everyone who cares. We should probably figure out how to respond. And the Women's Funding Network has some guidelines on what to do if you see this signal for help. So with that, I would like to turn it over to Elyse, who is the Director for Violence Intervention and Prevention Services at the Harrisburg YWCA. And I'm hoping she can share some of her reflections on what we have, what she has seen during the COVID-19 pandemic, how they've either changed or modified their processes, or basically anything that you can share from your perspective. Because I know every organization is different.
Absolutely. Thanks so much, Jen, for asking me to be a part of this. I remember a couple years ago when our program was getting monitored by our state coalition, they came back and said, "Hey, you don't have a pandemic policy." And I remember being really honestly annoyed that I had to write one, because I really didn't see how what they were asking was going to be relevant. However, I wrote one, and thankfully, unfortunately, we had to use it, but I at least had something in place to draw from, because I know a lot of programs were stuck very quickly trying to figure out what to do, how to respond, how to keep people safe, how to keep shelters running, because that's really an essential part of what we do. The YWCA provides domestic violence services in both Dauphin and Perry counties. We have wonderful partners in the community. I know there's a representative from the Victim Witness Assistance Program on the call. And they are really instrumental in helping us make sure that victims have access to protection orders right now. The WISE role with protection orders is to help folks with obtaining emergency orders. We actually haven't seen an increase in those orders right now, and at least on the emergency side of things. I know we get lots of calls about the temporary though, and we send those people over to Victim Witness, and I know they are often very, very busy during the day. Everything right now is being done through telephone, which creates a problem for folks who might not have access to a telephone or might not have a safe place to go to make those calls. I'm not sure that any of those situations have happened yet. But I do know that it's something that the Y and victim witness are very aware of as a potential as this pandemic continues and as our courts continue to operate on this sort of adapted way of doing things. Our shelter remains open. We have a 16-bed shelter for everybody in Dauphin County. We have 6 beds for folks in Perry County. Those 2 facilities remain full. It's typically a 30 to 45 day program. We're not asking folks to leave though. People who might have normally timed out or we might have worked with to get to next step housing, we're sort of just letting them stay where they are. We also haven't had to turn many people away. And when we have to turn people away, we always provide other resources, other shelters. We offer hoteling for folks that we can't house immediately. We've really seen a decrease in people reaching out for services, at least those supportive services like shelter and counseling. We've seen a decrease in our hotline calls. We operate a 24-hour hotline. We typically will get anywhere from 150 to 200 hotline calls every month. And right now, I think we're only getting maybe 2 or 3 a day. We're also seeing a decrease in calls from hospitals and medical providers right now. Typically, we might receive a call from a medical facility, I don't know, 2 or 3 times a week asking for somebody to come out and talk with somebody that they've identified through screening and assessment. I think since March 17th, we might have gotten a maximum of 5 calls total. And that's for domestic violence and sexual assault combined. Because we also respond to hospitals performing sexual assault examinations. So, I'm not sure if folks just aren't disclosing. If I know people aren't necessarily seeking emergency medical care maybe as much. I'm not sure what that cause is. But we also understand that there are other priorities right now, and that perhaps this isn't in the forefront of folks' minds. Yeah, I mean, we've definitely seen a decrease right now. So that article about with New York City not seeing so many cases, I also agree that people might not know services are still going on. They might not realize that those supportive services like those provided through Victim Witness or through the Y are still considered essential, and we're allowed to remain open. We have chosen to remain open, but sort of staff things a little differently. We are on call every day, 24/7. I have staff that are on the phone that are able to respond to our building if somebody needs something. But we are operating mostly remotely from home. If we have to come in, we will do that. Obviously, we're all wearing masks and taking temperatures. And then we do have somebody in the building every day for 4 hours every day to check on shelter residents. The YWCA actually has 100 beds. That's for domestic violence victims and for homeless women and children. So we have lots of people in our facility that we're worried about and checking up on every single day, making sure they have food and basic needs met, but also making sure that they're exercising some of those universal precautions and wearing their own masks and things like that that are important to maintain the health and safety of everybody in our building.
Thanks, Elyse. I just wanted, before we opened it up to questions, I wanted, or actually just wanted to leave some of these resources out here. So on the left, we have the National Domestic Violence Hotline, 799-SAFE, 800-799-SAFE, which is or www.thehotline.org, which has a lovely safety button where if you click on that, it'll go to a Google screen, just in case somebody walks into the room. There's a texting response from the hotline that if you text "love is" to 22522, this is more primarily used to provide information for teens on healthy dating behaviors, but certainly can be used to link people to services. And of course, there's a TTD line for people who are deaf or hearing impaired. At Hershey Medical Center, if you want to get in touch with Elyse or one of her colleagues, the number is extension 5188. However, Dr. Noel Ballantyne once told me many years ago, if you pick up the phone and say, "Get me that person who deals with domestic violence," because you can remember that, then they will get you to the right person. The domestic and sexual violence advocate can sometimes be confused with the medical advocate, which is a person that you might speak to if you are unhappy with your medical care and you don't want that person responding to these. So I like Dr. Ballantyne's idea of get me that person who deals with domestic violence. The Harrisburg YWCA crisis hotline is here as well. And then on the right side of the screen, have put some resources that you might want to use to help guide you in your, as we think about caring for individuals with who have experienced domestic violence. With that, I think Elyse and I are open for questions.
Thank you, Jen and Elyse, for that. So yes, we'll open it up to questions and discussion, whether they're for Elyse, for Jennifer, or anything if you want to go back to that case discussion. So again, feel free to unmute your microphone, or you can put your comments and questions into the chat.
I'll just add a couple notes to what Elyse was talking about for everyone's benefit. I think the lack of access to telephone is an issue. I know it's come up with a couple of clients that we've already had where they had the means to reach out to us to start the process for an order, but then lost that access, and so weren't able to then be able to follow up with the court to get that. I really think Elyse, you hit the nail on the head with people having other priorities right now while they're trapped in this home. Abusers are going to be using that guilt and the special status of their relationship as a means of keeping them away from getting other care. So they might think, yes, I'm going through this horrible feeling. I have all this pain. I'm getting physically abused and being disrespected, but this is the sacrifice I have to make right now for my family, is what a lot of people are thinking. I know I've already had a couple clients experiencing that very feeling who didn't end up filing because of that. And so all of this just to say, to echo the fact that it is actively happening. We've also seen a downturn in our numbers of people filing, but I think that has to do with the lack of access, the lack of knowledge that it's available. And what I have also noticed is that the severity in cases of people who are filing is a little more consistent right now. Whereas usually there's going to be a lot of variance in how life-threatening a situation is. Right now we've seen some of our worst have been lately. I'll put in the chat box the phone number for victim witness for any clients who are going to be seeking a civil protection order. Like Elyse was mentioning, the emergency orders are available through the YWCA's with their assistance. Those are the orders that last for the overnight, effectively. They're the immediate. But if anyone is not in a situation where they're looking for that but want to pursue the temporary order, by default, they can contact us directly. So I'll put the number there in the chat for everyone.
Thank you so much for that, David. There is a question in the chat. Can someone speak to on emotional abuse and the difficulty of identifying emotional abuse?
I can try to take a swing at that. I think that with emotional abuse, I mean, if you look at the CDC guidelines, there's a lot of different questions. I think it's referenced in the box material. So there's a lot of different ways the CDC has identified emotional abuse. The way I think about it, because there is another form of violence called common couples violence, which I think some in the psychology community would say it's the more common form of violence. And I think the way I think about identifying emotional abuse is there a power and dynamic asymmetry? So when you're thinking about domestic violence, domestic violence by definition has an asymmetry of power and control. So if in the setting of couples who are, maybe they fight, maybe they belittle each other, if there's evidence where one is controlling the other, one has power over the other through the use of that form of emotional abuse, that's where I would, it's one of the ways that I would try to distinguish and identify domestic violence. Love to hear what some of the other experts on the call have to say about that.
Yeah, you're right. The power imbalance is key. Sometimes clients will be reaching out and they'll say something about, but we've both been abusive, and what I find that they're often thinking of in their minds is we have both used physical force against one another. But abusiveness is not just about physical force, as you covered in the beginning. That is one tactic that abusers are going to use, but ultimately it is about the level of control that they're able to exert over their partner. So that's the key thing to be looking for as you're talking with your patients and with your clients is about what is the feeling that they have on the partner. Are they being disparaged? Is connecting with anyone else in their life viewed as a threat to the relationship? Is that viewed as I don't know, like an indiscretion? Are they being accused of cheating constantly without doing that? Are they is their freedom of movement, is their freedom of communication being limited? Those are some of the telltale signs that a more dangerous situation might be developing because of those lower level controlling tactics.
I think the other thing that's really important to keep in mind is that some of your patients might not identify that anything is wrong. Oftentimes the people that we work with, for example, who come in for our homeless and housing programs, they might not be here for domestic violence services, but after their caseworker talks with them for a while, they start to notice some of those red flags and indicators. And when my staff goes over and talks with them, they are really shocked when we talk with them about some of the emotional abuse tactics, because this is what they've grown up with. It happened when they were children with mom and dad. It happened in their early teen relationships, and it's all that they know. So it's really normalized for some folks. So sometimes a lot of education is needed to even get somebody to the point where they identify that something is wrong, let alone getting them to the point where they say something is wrong and I need some help.
Thanks, Elyse. That's a really important point. I mean, sometimes we may use these terms in intimate partner violence, domestic violence, but I think we have to use words that the patient understands. I refer to them as patients. I know you refer to them as clients, but that can be tricky. And so sometimes I think it's important to identify, to reflect back to them that I see what you're telling me. When I hear this, often it reflects that there may be that this is not a sign of a healthy relationship, and that there may be more troubling issues happening within the relationship. And I've seen this before, and this is something that we need to talk more about.
Well, thank you, Kathy, for that question, and for everyone who provided input. If there are other questions, again, feel free to use the chat or unmute your microphone. And especially if anyone else has additional thoughts or questions around Kathy's point.
Yeah, I do have one other point. Something that I think can be really helpful and frustrating is recognizing that, especially as outsiders to a situation, your patient may describe something to you that in your mind, that's horrific. Maybe it's a physical attack, maybe it's a rape, it can be any number of things. But in their mind, the greater betrayal might be something that sounds to you like significantly more minor. I've had a client who, after describing to me a lot of things that I was almost agog at, then she said, and then after all that, he cheated on me. And then she broke down crying. And for her, that was the crux of it. Another client that I've had this week, it was a situation where his abuser had threatened suicide and said that he is the fault of it. That's his fault. And that was the crux for him of everything. So it's important to just recognize that what they're saying to you is going to have a different weight to them than it may to you. Yes.
Thank you for that. There are some positive comments in the chat. I won't read them. Jen, I know you're monitoring that. Any other questions, comments?
I do realize, thank you, Jen and David and Elyse for your comments. I think this whole issue of telehealth does pose very significant issues that I don't think that we will have solutions to anytime soon. And I agree with you, Jen, when you said, identifying a lurking person. It's not, none of those things are realistic, in that we really don't know what that really means. I know when I was in training, when I was in residency, Dr. Achilles used to give lipstick with information inside of it to patients that he was concerned about, so that they could discreetly have information at their fingertips. And I thought that was a clever way to hide key information, but that's not really an easy way when there are very tech savvy, controlling people out there. And I personally, as a physician, I'm not sure that I would feel comfortable asking any of these questions, even if the patient verbalizes that they are comfortable with the telehealth scenario. I'm not sure that I would feel very comfortable asking those questions because of my own biases of how easy it is to hack a conversation within being in the home, and how dangerous you could make a situation by adding those pressures. So I don't know if anybody has comments on that, and if maybe this is something that we should halt or consider halting during telemedicine until we have a better solution. But I don't know. I don't have the right answer.
Thanks, Paula. I actually would like to throw that one to Elyse, because this is what they've, they do this sort of all day long now, tele assessments for domestic violence. It's kind of where they're working. So I'm not sure if you can share what you feel the best practices are, or how you ensure safety or satisfy yourself that you're safe.
I think this is always a challenge, and I'm sure David, please weigh in too when I'm finished. Because only the survivor knows the potential danger and lethality to the questions that are being asked, to their responses, to their nonverbals. Because even if they are saying no out loud, if their perpetrator sees them and they think that they're shifting their eyes a direction, or that in itself can be dangerous. So when folks are calling the hotline to speak with us, we ask them if they are safe. And again, safety means a lot of different things to a lot of different people. And if they say they are, then we sort of allow them to share with us what they feel they're able to share. We don't ask questions about what kind of abuse they're experiencing. We sort of let them lead the conversation. Now, when we have scheduled appointments with folks, we also ask them to call in to us at a time that is safe. We aren't cold calling people typically. And if they call in to miss an appointment, it's not something that we are holding against them ever, but especially right now when things just might not be safe for them to do so.
And thank you, Elyse, because I think that's completely appropriate and very different from how I envision we are screening and maybe even addressing things as physicians, or how maybe the telehealth is directing the screening in physicians, and that maybe those things need to be reevaluated, like, hey, contact us, rather than a direct asking questions. I don't have the right answer, but I do think a victim of domestic violence could feel issues with fear and feel threatened from having to answer those questions, potentially in front of, or potentially get hacked by their perpetrator.
Thank you, Maria and Elyse, for that. I hate to break up a party here, but it's 10:01. We do try to stay on time. It does sound like telehealth for for violence assessment might be another topic to be considered for a future ECHO. There's also a comment about child abuse that has increased during this pandemic. So I'm not sure if that will be something that we'll be able to follow up on, but if anyone has thoughts, suggestions on those topics, please let us know. And I'm just going to wrap up quickly. A reminder that you are able to collect CME and attendance for participating today. There's always a survey following each session. You can use that same survey link for each session that you attend. All materials will be shared via email. And finally, we hope you'll join us. Our next ECHO session is this afternoon at 4 p.m. This is part of our COVID-19 Skilled Nursing Facilities ECHO series, and it's going to be focusing on optimizing medication management during the COVID-19 pandemic, an implementation guide for post-acute and long-term care. So we hope that we will see you then, and please continue to watch your email for additional sessions. Thank you and have a great day.